Thank you so much for joining us today. I want to welcome everyone to the second to last of the STS 2023 webinar series. Today's webinar is titled Biomarker Testing and Neoadjuvant Immunotherapy for Resectable Non-Small Cell Lung Cancer. This webinar is the second in a two-part series supported by AstraZeneca. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. Right now, to attend the STS, join right now to attend the STS 2024 annual meeting. Attendees will experience 3 full days of sessions covering the latest research for cardiothoracic surgical professionals of every discipline and at every career level. Medical students and resident fellow members register for free. So register now, and you can use the QR code up at the top. At this time, we are pleased to introduce our moderator for this evening, Dr. Robert Merritt. Welcome, Dr. Merritt. Let me turn it over to you.
Thank you. Good evening, everyone. Welcome to this great, outstanding STS webinar series. I would like to thank AstraZeneca for their sponsorship. We have a great program. We have 2 outstanding speakers who are experts in the field of immunotherapy who will be giving talks. So first, I'd like to introduce Dwight Owen. He's an associate professor of medicine at the James Comprehensive Cancer Center at the Ohio State Wexner Medical Center. And he will be giving a talk on biomarker testing. Thank you, Dwight.
Thank you so much, Dr. Merritt. Thank you so much, everyone, for the invitation to this conference. Can everyone see my slides okay?
Yes.
I'll take that as a yes. Perfect. Thank you. So as Dr. Merritt mentioned, I'm an associate professor and a thoracic medical oncologist here at Ohio State, working closely with Dr. Merritt, and it's my pleasure to discuss tonight biomarker testing and neoadjuvant immunotherapy in resectable non-small cell lung cancer. My hope for tonight is to convince everyone of the importance of biomarker testing, both in driving clinical decision-making, as well as enrollment in clinical trials as we expand in this space. Here are my disclosures. These are all grants to conduct clinical research at Ohio State. So I wanted to cover a few areas tonight. I'm going to spend the majority of the time on the first 2. So the first is PD-L1 and a little bit about PD-L1 as a biomarker in resectable disease, but also the importance of identifying better strategies for patients with PD-L1 negative tumors. Second, I'm going to talk about the importance of knowing a patient's mutational status in terms of EGFR and ALK, but also other alterations. And lastly, I'd be remiss if I didn't at least mention the excitement that we've seen in mRNA personalized cancer vaccines. For now, published data only in melanoma, but we're expanding into the lung cancer space in clinic. So as we go through, I'm going to go back and forth from lessons that we've learned in metastatic disease and attributing them to early stage disease, since we've now been using immunotherapy for patients with advanced lung cancer for approximately 10 years. So the first study I'd just like to highlight is the KEYNOTE-24 study. And this study really overnight changed the landscape for patients with advanced non-small cell lung cancer. This was a global randomized phase 3 study of pembrolizumab versus chemotherapy in a very select group of patients whose tumors had very high proportions of the biomarker PD-L1, the target for pembrolizumab and nivolumab. This study was initially published in 2016, and at the time of follow-up here in 2019, where we had several years of follow-up data, it was very clear that patients treated with pembrolizumab had much improved overall survival compared to chemotherapy, with a median overall survival of 2.5 years. So a median overall survival of 2.5 years compared to 14 months with chemotherapy in patients who didn't have an actionable alteration in EGFR or ALK or others for whom better target therapies have been available since for the last 15 or 20 years. And this really overnight changed the practice of these patients, offered a non-chemotherapy option for patients, as well as a really durable survival benefit that we just don't see with chemotherapy. However, this was only in the very high proportion of PD-L1. So very soon after, we saw 2 follow-up studies, first in non-squamous, and then followed in squamous. These are the KEYNOTE-189 and KEYNOTE-407 studies. Both of these studies combined pembrolizumab with chemotherapy. So in patients with PD-L1 negative or low non-small cell lung cancer, pembrolizumab by itself was less effective, and so the combination with chemotherapy was explored. And in both these studies, there was an improvement in overall survival with the addition of pembrolizumab. And at the time of first publication, as you look at the hazard ratios below, there seemed to be a benefit across the board. So patients with PD-L1 positive or negative tumors seem to derive a benefit from the addition of pembrolizumab. Here is now 5-year data from the KEYNOTE-407 study. So this was a study that was focused specifically on squamous non-small cell lung cancer, again, pembrolizumab plus chemotherapy or placebo plus chemotherapy. And as you can see, along the entire stratum of 5-year follow-up, there was an improvement in survival with patients treated with pembrolizumab, which translated to a 17.2-month median overall survival compared to just about 1 year. So not as impressive as the PD-L1 selected high population. However, looking at specifically the 5-year follow-up at 60 months, almost a doubling of survival. So patients with metastatic disease alive at 5 years, 18.4% treated with pembrolizumab as first treatment with chemotherapy compared to 9.7% with chemotherapy alone. But here's where we start seeing some important differences. So now I'm showing you just the data for PD-L1 negative squamous non-small cell lung cancer. And here the difference disappears. So first of all, the median overall survival is shorter at 15 months compared to over 17 months. But just as important, and perhaps more important in terms of the durability of the response, the 5-year overall survival difference disappears. And in fact, numerically, there were more patients alive who were treated with placebo compared to pembrolizumab. This really highlights that this specific patient population, PD-L1 negative non-small cell lung cancer, squamous specifically, but in both histologies, do not derive as much benefit from immune therapies. And of course, this is not limited to just the metastatic setting. So here I'm showing you the EMPOWER-010 study. So this was adjuvant atezolizumab after curative surgical resection, followed by cisplatin-based adjuvant chemotherapy, then randomized to atezolizumab or standard observation. And as you can see from the DFS curve, improvement in overall patients treated with atezolizumab compared to observation. This is looking specifically at stages 2 and 3. However, when you broke things down specifically by PD-L1, the benefit disappears. For the PD-L1 negative patients, there was no statistical improvement to adjuvant atezolizumab. And in fact, the adjuvant atezolizumab is only approved for PD-L1 positive non-small cell lung cancer. The same holds true for locally advanced unresectable non-small cell lung cancer. So here is the overall survival data from a follow-up publication from the Pacific study, which randomized patients who had completed chemotherapy and radiation for advanced unresectable non-small cell lung cancer, randomized to durvalumab for a year versus placebo. So this is a placebo-controlled study. And again, overall, looking at the patient population in the entire study, significant improvement with the addition of durvalumab compared to placebo. However, when you look at the PD-L1 negative subset below, not only is it not statistically significant, but it actually trends the wrong direction. The hazard ratio was 1.36 favoring placebo, although again, it crossed 1. I will mention here that this study was not powered based on PD-L1, and in fact, about a third of patients didn't have known PD-L1 score, which may have skewed the results. But still, it's pretty clear that across metastatic and locally advanced and early stage, that these patients are not benefiting as significantly as the PD-L1 positive subset. And of course, leads us to the discussion today. So there are multiple now randomized phase 3 studies of preoperative or postoperative or perioperative immunotherapy combined with chemotherapy, typically before surgery, followed by adjuvant immunotherapy in some studies. And Dr. Donington will go into detail of some of these studies, but I just wanted to highlight some nuances of these. So this is what most of the studies look like in the preoperative setting. So these are patients with very often the 7th edition of staging. Some included the 8th edition, so stage 1B to 3A. And I'd like to highlight no known sensitizing EGFR ALK alteration. So we had to know that they didn't have EGFR ALK in order to enroll patients into these studies. Patients with any PD-L1 are allowed, although patient outcomes were typically stratified by PD-L1. Then patients were randomized to either nivolumab plus chemotherapy or chemotherapy. This is the Checkmate 816. Keynote 671 was pembrolizumab. Aegean was durvalumab, and so each study was a combination of chemotherapy plus immunotherapy versus chemotherapy. Most studies were powered on event-free survival from time of randomization, so that you captured how many patients did not undergo curative intent surgery. And then we also look at pathological complete response or major pathologic response as well. And of course, what we know now is that patients who are treated with chemoimmunotherapy in the neoadjuvant setting have a higher rates of pathological complete response compared to chemotherapy alone. And those patients who do obtain a pathological complete response have exceptional outcomes compared to those patients who don't. Here showing on the EFS curves showing that those patients in the solid green who received nivolumab plus chemotherapy and had a path-CR had really exceptional outcomes. It's true that even patients with chemotherapy who had a path-CR had great outcomes, but there are just numerically so many fewer of those patients. So it's true that pathological complete response is its own biomarker for how we expect patients to do post-surgery. And here I'm showing data from the KEYNOTE-671. So this is the other currently approved option of pembrolizumab plus chemotherapy. There are some nuances. The chemotherapy was cisplatin only, and in this case, pembrolizumab was given after surgery. But it's clear that there's a definite separation between those patients who have a path-CR versus not, and those patients who don't achieve a path-CR. Those treated with pembrolizumab still had superior outcomes in terms of EFS, at least, compared to placebo. And we now have follow-up data that overall survival was also significant in this study. But what about PD-L1 that was so important in the metastatic setting? So here I'm showing data from CheckMate 816 for path-CR and PD-L1. So we know that patients with PD-L1 negative tumors can achieve a path-CR, and if they do, they have excellent outcomes. So on the left, PD-L1 negative, and on the right, PD-L1 positive. In both groups, patients who achieve a path-CR have significantly improved EFS compared to those who don't. It does seem that patients with PD-L1 positive disease who have a path-CR do exceptionally well. What's also clear is that patients who don't achieve a pathological complete response have earlier risk of recurrence, and those patients whose tumors are PD-L1 negative, that's even more significant. And here I'm showing data from the NeoTorch study, which nicely laid out the PD-L1 negative on the left, PD-L1 low positive in the middle, and PD-L1 high positive on the right, showing that the hazard ratio, although it's 0.59 for PD-L1 negatives, it crosses 1. It's not statistically significant, and you can certainly appreciate that the curves are much wider for the PD-L1 positive disease. And for the two currently approved regimens, 816 and 671, very clearly set out here in terms of hazard ratios for EFS. PD-L1 negative subsets in both were not statistically significant. I would also highlight this also shows that patients with stage 3 disease also clearly had the largest benefit in terms of EFS. So what to do for patients with PD-L1 negative disease? Well, here on the left, I'm showing you data from CheckMate 227. This is in the metastatic setting for the addition of a CTLA-4 inhibitor, ipilimumab. So combining nivolumab plus ipilimumab versus nivolumab or chemotherapy alone, or the combination. And what you can see is that the patients treated with nivolumab plus ipilimumab in blue had longer survival and better outcomes compared to either of the other regimens for those patients with PD-L1 positive disease. But what really struck us in this study was what's on the right. For the patients with PD-L1 negative disease, the benefit seems to be even greater. There seems to be a wider separation of the curves. And one of the most important things that we saw in this study that we haven't seen in others is that the median overall survival was no different for PD-L1 positive versus negative, whereas when checkpoint inhibitors are given by themselves or with chemotherapy, there's certainly a survival difference. And as it happens, Mark Awad and colleagues have presented this data earlier this year at ESMO. So CheckMate 816 had a Nivo plus IPI arm to it. It was considered an exploratory analysis population. It was closed earlier when it seemed that the nivolumab plus chemotherapy cohort would be moving forward. And what I would, a word of caution is just, it seemed that there was a much higher rate of canceled surgery with nivolumab plus ipilimumab compared to what we saw with the other arm of 816 of Nivo plus chemo, with 26% of patients having surgery canceled, mostly for disease progression, which is different here. Now I'm showing you from the publication of 816 for Nivo plus chemo, only 15% of patients had canceled surgery, still higher than we would like, but not nearly as high as with Nivo IPI. And the reason for disease progression was actually much less common. And here we see it in the EFS curve. So we sometimes see this early crossover when immune therapy is given by itself, where there are some patients who have early progression. Over time, of course, the immune therapy shows a durable response. However, it's that early crossover that we worry about. And when we're trying to give therapy before surgery, that early progression could jeopardize surgical outcomes. So this is something for us to consider with caution in the preoperative space. So in summary, thinking about PD-L1 as a biomarker, there are significant improvement in EFS and PAT-CR rates in patients with PD-L1 positive tumors, as well as in patients with stage 3 tumors. And now we also know that this has translated to an overall survival benefit. We know that PAT-CR is essentially a new biomarker, a patient's own biomarker for how they responded to treatment, which may guide selection of adjuvant therapy. And we know that escalating therapy in the preoperative setting may come at the risk of surgical delays and potentially cancellations. Turning now to actionable mutations and alterations. So I just want to be clear, there is no currently approved targeted therapy to be given in the neoadjuvant space. However, there are multiple options in the adjuvant setting, and there are implications for preoperative treatment that I'd like to highlight. So this is the ADAURA study. This is a global randomized study of patients with EGFR non-small cell lung cancer, randomized after surgical resection to either osimertinib or placebo. Patients may or may not have received chemotherapy. That was not mandated, although most patients did. And a few years ago, we saw this presentation at ASCO, and there was a very clear benefit in terms of DFS for treatment with osimertinib with a hazard ratio of 0.17, pretty incredible. So obviously, these patients were not having recurrence of their cancer during the time of their treatment. And most recently, we saw the overall survival data published earlier this year. So that perhaps unsurprisingly, that significant DFS advantage translated to an overall survival advantage. There are some issues with the study that I won't go into. There essentially wasn't a crossover for those patients who did recur. It would be interesting to know whether delayed treatment versus early treatment really had the same difference in terms of overall survival. The strongest benefit was in the patients with stage 3 disease, although looking across all stages, there was an improvement in overall survival. If you look at the top, those patients treated with osimertinib, this is just stage 2 to 3A, 85% of those patients were alive at 5 years, compared to 73% with placebo. So this is a standard option for patients with stage 1B to 3 resected non-small cell lung cancer with an EGFR mutation. So what about ALK? ALK is less common than EGFR, perhaps 2 to 5%. This study was just presented at earlier at ESMO, the ALINA study. The main difference here was that, other than it being ALK instead of EGFR, was that it actually randomized patients with the targeted therapy, alectinib, compared to chemotherapy. So the target therapy instead of chemotherapy. And here's what we saw in terms of DFS. A DFS hazard ratio of 0.24. After a median follow-up of almost 28 months, the median DFS was still not even reached for the alectinib-treated patients, and firmly placing this as an option for our patients. So if target therapy is better than immune therapy in the adjuvant setting, what about combining chemotherapy and immune therapy? And from the metastatic disease setting, we do know the answer to that question. This is Keynote 789, which was chemotherapy plus pembrolizumab versus chemotherapy alone in patients with EGFR non-small cell lung cancer. And essentially, there was no survival benefit in terms of DFS or overall survival. And unfortunately, we know that patients with EGFR non-small cell lung cancer are potentially at higher risk of toxicities from immune therapies. And that's what we saw here, a doubling of the rate of immune-mediated adverse events, and unfortunately, a doubling of the grade 3 or higher immune-mediated adverse events with pembrolizumab. So it wasn't efficacious, and it was more toxic. And beyond EGFR and ALK, we know this for RET as well. For RET non-small cell lung cancer, here the targeted therapy is selpercatinib. This is again a metastatic first-line setting compared to chemotherapy plus pembrolizumab, and superior outcomes for the targeted therapy. So what I'm trying to highlight here is that we know that targeted therapies are better than immunotherapy for a subset of patients, specifically EGFR, ALK, and RET, potentially ROS and others. So the mutation status matters. I would highlight that KRAS and BRAF are potentially exceptions to this, but focusing on EGFR, ALK, RET, and ROS initially. I didn't go into this, but immunotherapy plus targeted therapies have been studied. And in lung cancer, those studies did not show a benefit and were highly toxic. Some trials had to be stopped early due to fatalities. So currently combining the options the therapies is not an option. We also know that patients with EGFR and ALK positive non-small cell lung cancer were excluded from the preoperative studies. So therefore, testing is needed to rule out one of these mutations. And sort of that's my take home is testing must be done to rule out EGFR and ALK, and also for PD-L1 before deciding on a perioperative approach. I'll make one more point, which is that in the metastatic setting, we know from a few years ago from Matt Hellman's group when he was at Memorial that the sequence of immunotherapy and targeted therapy matters. So patients treated with immune therapy first, followed by targeted therapy have higher rates of severe immune toxicities compared to those patients treated with targeted therapy followed by immune therapy. On the top is a heat map of patients of how soon they received their targeted therapy after immune therapy from the last dose, showing that the toxicity rate earlier for those patients who had them in close proximity was much higher. And then that's shown on the bottom is if specifically for osimertinib, the longer you went from your last immune therapy, the better your outcomes. So if the sequencing matters, it's very important, and we might be offering EGFR therapy to patients after surgery if they have received preoperative immune therapy as part of a Checkmate 816 regimen. We may jeopardize their ability to get that effective treatment or increase their risk of having toxicities from it. So it's not just a matter of excluding those patients because we don't think they're going to benefit. It's also you might be hampering your ability to deliver effective care for that patient after surgery. In just the last minute, I just want to highlight cancer vaccines are entering the clinic. We saw earlier this year at ASCO, personalized mRNA vaccines showed improvement in recurrence-free survival in melanoma. Here are those data that were presented. Trials are currently underway in non-small cell lung cancer. There's a very high burden of tissue requirement to develop the neoantigen vaccine. And so currently I envision this to be mostly deployed in the adjuvant setting where the amount of tissue is typically not as much of an issue. Although hopefully this is something that may benefit our patients in the preoperative setting in the future. So in conclusion, biomarker testing really drives clinical decision-making in perioperative non-small cell lung cancer. This should be done as part of a multidisciplinary discussion. I didn't get into the details, but I think every clinic is going to have to identify the logistics for streamlining the testing of our patients, depending on who's the first point of contact with that patient. At a minimum, patients should have PD-L1, EGFR, and ALK known. I would say if any patient is planned for neoadjuvant therapy, as well as any patient who's had resected non-small cell lung cancer. I will end with one sort of challenge and then one cause for optimism. So unfortunately, rates for testing in metastatic disease are low. These are data presented 2 years ago by Deborah Bruno. Less than half of patients in the time frame from 2017 to 2020 who should have had comprehensive testing did. So 48.7. Only 3/4 of patients had any biomarker testing. So we're unfortunately not testing patients that we should, and even worse, there are disparities in terms of who's tested, and this has downstream ramifications in terms of not just identifying the effective treatment options for those patients, but also enrolling patients on clinical trials based on what might not be a currently approved target therapy. So I'm hoping by identifying the opportunities and challenges from the metastatic setting that we can avoid seeing this discrepancy in the earlier stage setting. And lastly, many of you may know that the American Lung Association put out its State of Lung Cancer last month. The 5-year survival for all patients diagnosed with lung cancer is now over 25%, which is up from 22% just recently. But unfortunately, this varies from state by state in the country. And overall, we all have work to do, even though it's very encouraging. So thank you very much for your time and for the invitation. I'm looking forward to the panel discussion later.
Thank you, Dr. Owen. Excellent talk. So our next speaker I will introduce now, Dr. Jessica Donington. She's a professor of surgery and the chief of thoracic surgery at the University of Chicago, and a recognized expert and thought leader in lung cancer. Dr. Donington?
So thank you. Thank you for the invitation, and thank you for the STS staff for making this all so easy. Let's see if I can figure out how to share my screen. Oops. Let's see, let me try again. All right. So I'm going to give you an update on the recent immunotherapy trials, primarily the neoadjuvant trials for resectable lung cancer. Dr. Owen gave you a little bit of a start into this, but hopefully we'll go through it in a little more detail. So this is what the lung cancer kind of landscape looks like. And I put that arrow there because that's when I came into lung cancer care. And God, it was not very exciting back then. We were doing everything basically as we had been since the 1970s. And our survival really wasn't that much better than the 1970s. It was sad and pathetic. But really, since 2005, it's been a fast and furious advancement in lung cancer care, with lots of advancements in the metastatic or stage 4 setting, with targeted therapies and immunotherapies. But I think in early stage disease, we have similarly made a lot of advancements. Adjuvant platinum, adding SBRT so patients didn't have to go without treatment. And then I think the minimally invasive resections, ERAS protocols, sublobar resections, all those things really got our patients to be in a much better place to combine surgery with other therapies. So now in 2023, not only do we see adjuvant EGFR and ALK work, but we also see a lot of, in terms of adjuvant immunotherapy, neoadjuvant and perioperative immunotherapies. And I think if our techniques hadn't improved, I don't think our patients would have been as ready for these advances as we see them now. But that also means that so much has changed. When you look back to 2015 and 2023, there are almost no patients who are treated the same way, except maybe the 1Bs, like this weird little group here who we don't quite do sublobar resections, and we don't quite add immunotherapy, but otherwise every single patient really gets addressed differently. And today I'm really going to focus on this now kind of big swath in the middle of lung cancer, which I always say is not really early stage because it's not the stage 1s, but everything from 1B and 2 through resectable 3A, which we now approach with many new agents. This is what the kind of the immunotherapy landscape looks like with all the new trials which have reported in the last couple of years. The 2 adjuvant trials, which we've seen, are Empower 010 and the Keynote 09 looking at atezolizumab and pembrolizumab. And then this bigger set of boxes down here are the neoadjuvant and peri-adjuvant trials. And right now, I tend to really look at those together. And that's because I think in terms of the results that we're seeing right now, we are really only seeing the effect of the neoadjuvant arm of these peri-adjuvant trials. So everything we compare, I think, is still okay to compare pretty head on with the Checkmate 816 trial. So we'll look at Checkmate with a little more detail, and the Checkmate investigators have been really good about parsing out data little by little and telling us more about this trial. You've already seen the schema, so we'll move through that pretty quickly. This was the first report out at ACR, when in 2022 we saw path CR rates and major pathologic response rates. These were, 12-fold. This is not something we had ever seen with chemotherapy before, and this really got everyone excited. And then we started seeing the event-free survival curves. This is the 3-year data, which was presented at the European Lung Cancer meeting last winter. And out to 3 years, 57% event-free survival and a hazard ratio of 0.68 is pretty impressive with the addition of nivolumab. This trial had about 2/3 of its patients, I think, or 3/4 were stage 3. So this is primarily a stage 3 population and really better survival than we had seen in other trials. Oops. The Checkmate investigators have then parsed this up in several different ways, all of which is very informative to us. So this is event-free survival with and without definitive surgery. And I know you would say wasn't surgery an event, but this is like they called event-free survival 2, which was like everything except not going to surgery. But you can see that, we really see a dramatic difference in survival between those patients who went to surgery and those patients who did not go to surgery. And that was regardless of whether they got the nivolumab or not. So you would assume that a lot of these patients who fall off very quickly are probably patients who progressed, since about 1/3 of the surgeries were canceled due to progression. But you can see that those curves drop off pretty quickly. And with all, very few patients alive out past 3 years if they did not go to surgery. Similarly, some data that we saw a little bit earlier, looking at the impact of PD-L1 expression in these patients and that impact on their event-free survival. So we see a much more dramatic improvement in event-free survival in those patients who are PD-L1 positive compared to those who are PD-L1 negative, even though the trial allowed anybody in, and the FDA approval for this regime does not negate people who are PD-L1 negative. Oops, sorry. Forgive me. And these are what's called tornado plots. They look at the pattern of recurrence. And I guess not surprising to a lot of us in that we think this is a better systemic therapy. The tornado plots look pretty symmetric in terms of local regional recurrence, because I don't really know how much a good systemic therapy can stop that, but that the real advantage of these medications is in terms of a distant recurrence, where we see, you know, half as many patients with distant recurrences, and similar to other trials, great protection against spread to the brain. The little box all the way over to your right looks at those patients with brain metastases in greater detail. First, if you go to the top line, we can see the stage. Most of these patients who had brain mets were patients who were stage 3. People know least about, because it is out of China and uses a medication called toripalimab. But otherwise, the other thing that's unique about this trial is that even though the trial was open to stage 2 and stage 3 patients, what was reported at ASCO last year was just for the stage 3 patients. And I think that's one reason we see that really nice separation in survival and the EFS curves. It's always a little harder to show benefit in earlier stage patients. Then Keynote 671, this was also presented at ASCO this year, this one by Heather Wakely. Again, 4 cycles of pembrolizumab plus chemotherapy versus chemotherapy alone, then resection, and up to a year of adjuvant pembrolizumab. This was the event-free survival curves presented at ASCO. And then at ESMO, just this fall, we got the 3-year overall survival curves. And as Dr. Owens mentioned, this is our first trial that has an overall survival advantage for the use of perioperative immunotherapy. All the other data so far has been basically in event-free survival, where it hasn't quite crossed that barrier, that line to statistical significance. So this was a really big deal. And then finally, the last trial we had seen is the follow-up kind of the Checkmate 816 trial. It's Checkmate 77T. And it is similar to 816, but this one is a little different in that it has 4 cycles rather than 3 cycles of nivolumab plus chemotherapy, followed by resection. And then again, unlike Checkmate 816, it did require the year of nivolumab after surgery. But again, the event-free survival that we're seeing is primarily, what we see from the neoadjuvant part of the therapy. And again, very good with a hazard ratio of 0.58. It is a little bit early. If you look at where that line sits, it's at 18 months, not at 24. They gave us some good teasers with the Checkmate 77T data. So similar to what we've seen from the 816, they showed us survival by stage, which the advantage in the stage 3 far greater than what we see in the stage 2 patients. And then survival by PD-L1 status. So, a much less dramatic improvement in those patients who are PD-L1 negative compared to those who are positive. And I think as I look at curves like this, I think about, there'll be a day when, you have a stage 2 patient who's PDL high versus PDL low versus PDL negative, and you might think very differently about what we treat them with. Right now, it's a little bit all comers, but I think we will soon become much more sophisticated, and the perioperative regimes will look much more like what we do in stage 4. So now a little bit of these are all like, this is where I have to like apologize. These are all my own slides. I do some cross-trial comparisons here, and we're going to look at how these trials line up one next to the other, because it's a lot of information to put together. So this is kind of their schema and how they all put together. Again, Checkmate is the only pure neoadjuvant trial. All the rest are periadjuvant. And it wasn't like they had options in there to give the post-op chemo or not. Everybody, I'm sorry, the post-op immunotherapy, everybody got it. So the perioperative trials are all much bigger, but they also all use a lot more therapy. Instead of 3 cycles, we're talking about 16 or 17 cycles of therapy. The inclusion of stage is exactly the same. When you move from the neoadjuvant to the periadjuvant, we changed the staging addition, but actually the patients included were exactly the same. Stage distribution was also quite similar between the trials, with, you know, about 1/3 stage 2 and the rest being stage 3 patients. Endpoints were also quite similar, except for the Keynote trial, which was actually powered to an OS primary endpoint. And again, EGFR and ALK mutations, when some of these trials started, they were not something that we had to test to remove, to exclude, but as the trials progressed and as we got the ADURA data, that became something very much that we saw. The other thing that why I say that what we're seeing is only the effect of the neoadjuvant phase of these trials is that this swimmer's graph compares the length of treatment to the median follow-up when the trial was initially reported, or where we have the data now. So you can see in Checkmate, therapy only lasts, you know, for less, 6 months or less. But when you get into these other trials, some of them have reported with less than half of the patients finishing their adjuvant phase of their treatment. Keynote, we did get a additional follow-up at ESMO, so its follow-up is out at 36 weeks. But for Aegean, Neotorch, and Checkmate 77T, we're all seeing follow-ups that are, 2 years or less right now. So we still have a lot of data and a lot of response to see. This is the path CR across the trials, and I think it's actually great. It all looks incredibly the same. We think these agents all work pretty much the same, and so the fact that we see similar results, I think, is very encouraging. And we see that both for path CR and major pathologic response, which is that 10% viable tumor. I think it is interesting that we can do the head-to-head between Checkmate 816 and Checkmate 77T. And in terms of path CR, adding that 4th cycle doesn't seem to give us any benefit. Now, it may be that we're just looking too soon, and if we were operated at 6 months rather than 6 weeks, we would see something different. But I do think it's an interesting comparison because we don't know what the optimum number of preoperative cycles are. I also want to put a shout out to this really nice work from the Checkmate group that's in Nature Medicine just this past month. And it's a much more sophisticated look at response pathologically than kind of the yes, no of path CR or not. And they really look at residual viable tumor as this, continuum, and look for really meaningful cut points in there that might, better define prognosis. This is the 2-year event-free survival from all these trials. Again, incredibly similar. And that's what we showed in all those graphs. And then these are the only 3-year overall survival results we have to date. And while they look quite similar, only the Keynote trial is statistically significant difference. And that really is, a thing about trial design. It would look like now it was a much bigger trial. So the difference didn't need to be quite as significant, quite as large to be statistically significant. This is my word of warning on these trials. So this is a bit of a complex graph, and my apologies, but it looks at the phases of therapy that patients who start it complete. So we start in the back at 100%. And then as you go through each phase, we see attrition of patients. And if you look at the peri-adjuvant trials, only somewhere between, 40 and 65% of patients are able to complete all of this therapy. And these are trial patients. These are our kind of healthiest patients out there. And it doesn't matter if it's the control arm or the IO arm. So we make a lot about that drop off between, starting neoadjuvant therapy and getting to surgery. And it's a very reliable 15 to 25%. But we see similar drop offs as we go. This is a lot of treatment for our patients. So I think we have to be really thoughtful about who gets what. And because the thought that we're going to be able to get everybody down this path, I think is a bit unrealistic. So my take home on all these trials, we do have to remember that Checkmate 816 is our only pure neoadjuvant trial. We have growing evidence for the perioperative setting, but I don't think we quite yet know the added benefit of adjuvant to neoadjuvant therapy. But we do see improved event-free survival with the addition of these medications before therapy. The early OS is very promising. All of our curves are really plateauing us, letting us think that this is really going to be a sustained improvement in survival. I think these medications and these regimes are safe. People are not dropping dead. We're not seeing pneumonitis. Our surgical complications haven't changed. But it's a lot of treatment. And attrition is an issue. And I think we have to be careful in thinking about who appropriately goes down these paths. And I think as surgeons, we do have to recognize this is more work for us and it's not going to change. We do have to understand the agents, the indications. As Dr. Owens mentioned, biomarker testing is essential and we can have delays and technical challenge. But for the survival benefit we are seeing, I think it is absolutely worth it and where our future lies. Thank you.
Thank you, Dr. Donington. That was an excellent overview of the neoadjuvant and perioperative immunotherapy trials. So now I'd like to invite Dr. Sandra Starnes, who's the Chief of Thoracic Surgery at the University of Cincinnati Medical Center, as one of our panelists, and Dr. Hari Keshava, thoracic surgeon at UC Irvine. And I encourage all of the attendees to submit questions through the chat or through the Q&A function. So I'll just throw out our first question. So I think the common thread between both of our talks this evening is that biomarker testing is essential in the era of immunotherapy. With that said, I'd like to ask some of our panelists, what is your current workflow for biomarker testing at your institutions? And do you do reflexive testing on all of your non-small cell lung cancer patients? So I'll start with Dr. Starnes.
Yeah, we do reflexive testing, although it doesn't always work out that way. Sometimes the pathologists have a hard time figuring out the stage. We don't do it on clinical stage 1A, but pretty much everybody else gets tested.
Great. Dr. Keshava.
Yeah, this is actually an issue that we've been having because our pathologists don't do reflex testing. So initially it's all been done by our oncologists, but now with a lot of these early stage patients, they're not going to our oncologists. So we're starting to do it ourselves, which is difficult to kind of implement. But I was going to ask how other people have implemented that. If you just kind of trust the pathologists, and how did they go around that kind of 14-day rule?
Yeah, I'll just comment. So at Ohio State, we get biomarker testing pretty much on every non-small cell lung cancer patient. There are challenges when we get patients referred from the outside who have already had biopsies, and there was no NGS or PD-L1 biomarker testing. So in those cases, it becomes challenging because then we have to either try to track down their tissue and submit it to our institution, which creates delays, and also it's insufficient amounts of tissue to perform NGS or PD-L1 testing. So in that case, sometimes we have to do repeat biopsies. So it is challenging when those patients are referred from the outside. But we do, we don't do reflexive testing, but we request it on all, the surgical specimens and any pre-op specimen we'll request it. And Dr. Donington, is that what you guys do at University of Chicago?
We're very similar. Luckily, most of our EBUSs and navigational bronchs are done by our interventional pulmonary team. They're an well integrated part of our lung cancer team, and they had already been sending reflexively biomarkers on anybody they were biopsying. So if someone goes for an EBUS, they will automatically get their NGS sent, and that patients are like all outpatients, so we would get it all reimbursed. And if they were going for EBUS, you knew they were going to have this issue. When we started, getting deeper into the neoadjuvant thing, the group that became a little bit more challenging was a little bit of those big tumors, the kind of 4 centimeter node negative, especially if they've been biopsied from the outside. Because I agree with you, Dr. Merritt, nobody from the outside ever had enough tissue. So we would have to tell them that, yeah, we're going back in, because, it takes one EGFR mutation that you've treated with, neoadjuvant to tell you that you did something wrong. I'm surprised that patients, when you tell them that starting with the right therapy is better than starting therapy now, how willing they are to redo that biopsy.
Right.
But the delay is painful. Oh.
Yeah, it is. No, absolutely.
Yeah, I would just add to that it's amazing to me that you would never treat a breast cancer patient without knowing their hormone status, HER2 status. I mean, and it's the complete package, right? That's all presented to us to make decisions, perioperative or metastatic. And it still boggles my mind that this isn't considered the same for lung cancer. And I don't know how that happened. I think it's up to Dr. Merritt. I mean, Dr. Merritt, I remember a tumor board where you presented someone, you added on the testing, you found an EGFR, you were like, I think this patient should get osimertinib. I was like, well, why don't you just, it sounds like you've done all the other work for us. But if you don't have that sort of collaboration, it can be very challenging, because